Perfect.
Sorry about that, guys. Thank you, Dusty. As Dusty mentioned, I'm Wendy Kennedy. I'm the Director of Revenue Integrity Services here. And happy St. Patrick's Day. I know this one's a little different than probably what most of you are used to. But I hope to at least entertain you, if not, hopefully give you some really great information today, maybe to discuss with your internal teams. I'm going to start out with our disclaimer, which you're probably very familiar with. This basically just says that, the information in this webinar is current today. And so if you're looking at this 2 years from now and there's any code references in here, they may be outdated. So let's get started. Learning objectives for this webinar are to explore 4 reasons to engage in an annual chargemaster review. Obviously, there are many, many reasons to perform a chargemaster review, but I wanted to talk today about the 4 listed here: compliance, reimbursement, revenue capture, and transparency. And hopefully everyone has had a chance to kind of take a breath. Hopefully you've got all of your transparency information posted out there on the web and have been able to kind of take a breath from that. Both the Office of the Inspector General and the Centers for Medicare and Medicaid Services recommend that a hospital's compliance plan include both an internal and external auditing to ensure compliance with regulatory requirements. So I'm going to begin the presentation first covering compliance in the CDM, as this should always be our main focus. I'll also dig into each of these other extremely important areas that are greatly impacted by the chargemaster as well. And then I'll share with you why I feel these are solid reasons for performing an annual CDM review. And as always, I'll try to sprinkle in some examples of issues that we have identified here at Vitalware during our previous client engagements to kind of help you with some examples and maybe some little tidbits of things to look for at your organization. And then at the end of the presentation, hopefully I have provided you with some topics, like I mentioned earlier, for internal discussions at your organizations and some great content for you to share with your leadership team if in fact you are hoping to reach out to an outside organization such as Vitalware to perform an annual chargemaster review for you. So I thought it would be a good idea to start first with how we approach this CDM review process here at Vitalware. This is a high-level overview. I'll try to go a little bit into each of these things, but I think this will be helpful just to kind of give you some perspective as how we approach this topic. First, we take a download of your CDM file and typically 12 months of revenue and usage data. That 12 months is super helpful to see those charges that you're not using anymore. If you have specific concerns, obviously we can expand that. We've had folks say, we haven't turned off anything in 3 years. So let's go back 3 years. If it says we haven't used it, it's an automatic inactivation. So we do that for lots of reasons, looking at those, easily identifying those things that you aren't using that maybe are obsolete and you can inactivate. But that revenue and usage data is a huge clue if we do see no usage on something that we would expect you to be using very frequently. So when we see those instances, we're going to bring those to your attention, have a conversation, and talk about why those items are not currently being used. We're very fortunate. I've been a consultant for a really long time. I've done these in Excel. I've done them all kinds of ways. Way back in the day, I might date myself, but we did these on green bar paper that we printed out and had about two 2-inch stack of paper that we had to go through. So what a blessing that I work for a company that has software that I get to use. So we do run that data through our Vital CDM technology and perform an analysis that gives us lots of great information that we can review and apply to the charge lines. We also then go the next step, and we do go line by line through the chargemaster file. So if you've got 42,000 lines in your chargemaster, we're going to look at 42,000 lines of your data, and really make sure that everything gets validated. We also, as a standard of practice, like to do a claims review, looking at, I'd say the standard number is about 100 claims. Depending on the size of your organization, that may go up or down. But really to see that chargemaster in action. So I know I've mentioned this in the past on webinars, but you can have the most perfect chargemaster file, but if folks don't know how to charge, it doesn't provide as much value. So we want to make sure that not only is the chargemaster clean and accurate and compliant, but also that the electronic mechanisms that we have in place are actually working as designed, and then also that anybody doing manually charging actually understands how to do that appropriately. So we like to see that in action, looking at your EHR, looking at the documentation, comparing that to the itemized charges, and then taking that next step to see how that came over to the claim, and did everything appear on the claim appropriately to allow you to get that reimbursement that you deserve. Once we've done all of that, we do typically come on site. We've been doing these most recently through Zoom due to the pandemic, and that's been working out great. Technology definitely has been our friend during this time, but we like to interview the revenue integrity team and all of the clinical department leaders, going through their charges, talking about, like I mentioned before, if we do see something that we would think, if we see 0 usage on an IV push in the ER department, that's going to trigger us to think something could be wrong. So we're going to have those conversations. We're going to talk about what's happening. And then we also may have identified that same issue in that claims review. We also like to talk about what each department's charging mechanisms are. So having a really good understanding of how those charges get triggered. So whether it is via an order or via documentation, or somebody's doing manual charge entry, you want to make sure that you understand how the charges are occurring. What is that charge capture process for each individual department, so that when you do find a problem, it's much easier to get to the root cause if you have a really good picture of how that whole process works. So we try to make sure that as part of that CDM review, since we're outsiders, we try to really understand. We ask lots and lots of questions to make sure that we are gathering a great understanding of what happens at your organization, and then also that our recommendations kind of coincide with that. We then, if you are a Vital CDM technology user, we can provide these recommendations, all of this feedback right back inside of the technology through the workflow process for you to process, which is really slick, and gives you that history that you can keep and refer back to. We wrap it all up into a executive summary of findings and recommendations. That's a narrative report, and then we stick with you for 6 weeks post-engagement to answer questions, help you implement those changes, and just be there by your side as you're doing the work. So this is what we do at Vitalware. If you're doing this internally, obviously this still works. Even those interviews, you may not have a completely thorough understanding of the charge capture processes with each of your clinical departments. And I think too, if you do work in the CDM space, sometimes those clinical leaders change. So really creating that relationship with those clinical leaders, as revenue integrity professional is super helpful as you're interacting with them. So the first thing I want to focus on, our first reason is compliance. So I stated before, our underlying focus of everything we do in healthcare should be compliance, whether that be from, billing compliance, coding compliance, clinical compliance. But every decision that we make as members of the revenue cycle team should always be focused on compliance. And obviously, we're all tasked with KPIs, such as like daily revenue, AR days, your DNFC, discharge not final coded, your DNFB, clean claims, denials rates. We've got all of these things that are put upon us to focus our energies on, but the underlying response to all of these should always be compliance. As part of our CDM review activities, we regularly validate the accuracy of all of the data elements within the CDM, the pharmacy, and the supply files. So we do try to extract those pharmacy files with the NDC codes and validate per the NDC that the HCPCS code is accurate. We focus on CPT, HCPCS, revenue codes, modifiers, drug multipliers, which is a big issue at some organizations. Again, those NDCs, and then the comprehensiveness of your charge description. So, is it easily understood what the description of the charge is? We might make recommendations to add some additional verbiage or content to your description. We try not to get, too picky with descriptions, because if that's what you call it at your organization and that's working, we certainly don't want to decrease the accuracy of charge capture. So the recommendations that we might make would be for consistency purposes, and then so those really important things, those things that add additional value for charge accuracy. So such as if something is to be charged each, we would recommend that you add each, so somebody knows they don't just enter it once, they need to enter it 4 times if it was done 4 times. And the lab, you're going to see qualitative, quantitative. For those tests where there are both types of results, we may recommend that you add those more descriptive words so that those can be validated for accuracy. And then, up to 2.5 centimeters for those laceration repairs, anything that's, in a length or per milliliter, so that you can ensure that the clinicians can clearly identify that it's the appropriate charge for the service that they provided, and make sure that something is getting charged in its entirety rather than you gave 300 milliliters, but you only charged it once. So this is also helpful, obviously, internal auditing to make sure that you can understand what the charge is. So understanding that verbiage, having it be more clearly defined is very helpful. Our system is also able to validate, that your CPT is valid. But we want to ensure also that your CPT code assigned to any particular charge actually represents that particular service. So thinking about the process of building a new charge, typically, let's assume the clinical department is going to start a new procedure. They're going to generate a CDM request saying, I need a charge for a chest X-ray. We're going to send that over to the CDM team, and the CDM team has to figure out, well, what is the right CPT for a chest X-ray? And so, making sure that that CPT code actually represents that particular charge description is super important. So that's one of the things that we catch line by line, because sometimes it is a real code, so the system doesn't catch it, but it's not the right code based on the description. So, best practice is that on a regular frequency that you would validate those descriptions with the CPT code. When we do find those, we're going to have a really detailed question and answer session with the clinical department, making sure that we understand the intent, that we understand that description as we read it, so that we can make sure that we are recommending the appropriate CPT code be applied on the back end. And then, just piggybacking on that, that is of concern. Obviously, if we're doing one thing and the CPT is something else, then we, again, coming back to compliance, that's an issue. And one thing that I think is helpful, one thing that we do for our clients is anytime we do find situations where it's the incorrect CPT code that has been applied, we're going to provide you with all the rules and regs that we can get our hands on for you to put in your toolbox for knowing that that is the accurate CPT code and how that should be used. And then obviously, once something like that is identified, need to talk about what does that mean? How many of those did you do last year? Sometimes we find an incorrect CPT code, but you only did it once in an entire 12-month period, so no one needs to send off any alarms. If you're finding that the wrong CPT code was submitted maybe 4,000 times, then you may need to get your compliance office involved and research, what is your approach to that going to be? Are you going to do any kind of self-reporting, or are you going to rebill any of the accounts where that was impacted? And sometimes it may be a CPT code that you don't even get separately reimbursed for, so you can take a deep breath at that point. So again, focusing on compliance, you're rarely going to hear a conversation about compliance without hearing the word risk in that conversation. And what is the risk to the organization if X happens? So piggybacking on what I just said about the CPT code assignments, CPT code assignment, carries a high level of risk, since the CPT code drives the reimbursement in most cases, in most situations, on an outpatient basis, especially in a PPS hospital. That CPT code is your driver. CPT codes, as you all know, are assigned both in the chargemaster and by coders. So you've got the coders applying codes, assigning codes as they're reading the documentation on a case-by-case basis. So each account is independently coded, and because of that, that would carry a lower risk than the assignment of a CPT in the chargemaster, because once we put that code in the chargemaster, that's used every time that procedure is performed. And so that then increases the risk if the charge is applied incorrectly, or if the CPT code assigned to the charge is incorrect. And so that's just, one other reason why it's so important to have a regular schedule of validating your chargemaster, reviewing all of that data, to keep on top of any of those things so that it doesn't get outdated and isn't inaccurate from a compliance perspective. Another thing to think about too is, you could receive a higher payment if you submit the wrong code, but you also could trigger a higher out-of-pocket cost to the patient. And so making sure that all of those data elements are accurate sometimes, can have a direct impact on what the patient pays out of pocket. So that's one thing to keep focus on as well. Obviously, Clear and concise documentation is necessary to support the charges that you place on each claim. The medical record documentation is the legal document of truth for each of those patient visits. And so some of the examples of documentation issues that we identify during our claims review is, some hospitals are still struggling with infusion start and stop times. This has gotten way better over the years, but there still are some folks struggling with that. Some of the electronic documentation could be creating some of that, but that's still something that we see sometimes where we can see it started, but we don't ever see where it stopped. And so justifying X hours of infusion therapy is difficult when you don't have that time written down. Also, sometimes we see that imaging procedures with contrast. It's clearly documented that contrast is used. Nowhere does it say how much they were given. That's pretty important to have in those, if not in the radiology report itself, in a nursing note somewhere as to how much was administered, just like any other drug type object. We also see discrepancies in observation time. Some of this is set up to do electronically. Other times it's a person reviewing the record to manually enter those observation hours. And then also making sure that people have a clear carve out policy for any of those monitor procedures. Because as you know, in an observation case, those monitored procedure, the time spent during monitored procedures has to be carved out of the observation time. So again, that documentation is extremely important. The next risk that we identify relates to charge explosions. We might find that a charge explosion has become outdated. Sometimes perhaps that's due to the procedure that's being performed has changed per technology. Maybe there was a charge explosion for an ultrasound guided biopsy, but now that's being done by CT. And so we've created a charge explosion with a CT, but that ultrasound is still in there. Or the guidance still says ultrasound guidance when now we should be using CT guided. So really keeping up with those charge explosions to make sure that all of the children charges of those charge explosions are up to date, accurate, still part of that package service as things change. So definitely looking at those on minimally an annual basis is really important. I think too, the more interaction you're having with those clinical departments, that they understand the charge explosions, they understand the ramification of that being outdated, that they need to come to you as they change their practices to ensure that those are still valid. And then with preference cards, sometimes we find that when those preference cards include a massive list of supplies that are typical for a particular procedure, and then for some reason, some of those high dollar supplies weren't used, sometimes those fail to get removed from the charging. So that's another area, is just, really looking at those preference cards and the usage of those. The next bullet here is, I feel, super important for reducing risk, and this is how you respond to your failed claims. It's extremely important that you are not increasing compliance risk by, working those failed claims incorrectly. So this could be in your internal pre-bill scrubber, or this could also be for those claims that are sitting out there in T status with Medicare, where your claim has been returned to you or RTP'd for you to correct it. So this might include, properly assigning modifiers like those XS, XU, XE, and XP, all of those impact reimbursement. And then they should only be added appropriately when that circumstance exists. So sometimes we find that we see a pattern of use of those modifiers where it seems that every single time two CPT codes are used together and every single account we look at, one of those old 59 modifiers is applied again every single time. And that can be a really slippery slope. As you know, by definition, those X modifiers are designed for special circumstances, like separate encounter or a separate structure or a non-overlapping service. So just because the modifier is allowed does not necessarily mean that that modifier is appropriate on each and every claim. So typically that's supposed to be a special circumstance, so that pattern of usage every time is the key that there may be something wrong. And that just may be a simple education to somebody who is working those failed claims. Industry best practice is those modifiers are applied on a case-by-case basis. We do see some of this hard-coded in people's CDMs. We don't encourage that. It's definitely something that needs to be thought out very well, just to ensure that someone doesn't, start charging the wrong charge and now you're adding a modifier that's not appropriate on every single case. So really doing those on a case-by-case basis is really your safest way to ensure you're reducing your compliance risk. And then the last bullet here, proper linkage between order entry or clinical systems and the CDM. This is key to ensure that what's being ordered and performed is actually what's being charged. So I love that our CDM tool allows our clients to pull in to the technology those ancillary files. So you can pull in an order entry file and link it to your chargemaster, which is super cool in my mind. And I really wish I would have done a poll. Of course, hindsight's 2020. I wish I would have done a poll here to find out, how many of you listening validate your linkages between your two systems and what does that frequency look like. I would love to hear more about that. As we get, system upgrades or new charges are created, you may get out of sync. And we have found on nearly every CDM that we've done where there's at least one charge where we're showing a usage of 0 and they're telling me they're doing that on a daily basis. And the reason that occurs is because it's coming from an order. Once it's marked complete, it generates the charge. So that clinical system goes over and finds that CDM number that's linked to it and sends that over to the claim. Well, when we looked in the system where the CDM code lives on the clinical side, it was blank. So there was the thought that it was linked to the charge, but it actually was not. So doing that linkage validation is so important to make sure that everything is working as designed. Because as you know, you can order that all day long, and if no charge goes anywhere, you're not getting your revenue, and no one's ever going to get a bill for that service either. And if you're running your, your revenue is going to be coming out of the patient accounting system, perhaps your productivity, and so it's going to be kind of trapped on that order side, and you're going to have not only loss of revenue, but perhaps loss of productivity as well. Next, let's talk about the CDM and reimbursement. So obviously an accurate and comprehensive charge master is, a key foundational element to be able to receive appropriate reimbursement. And on this slide, I've just listed several of the items that have a direct impact on reimbursement. So for outpatient reimbursement in general, is typically based on CPT revenue code, or perhaps if you're lucky and still have any percentage of charge payers. But it's imperative that the CPT rev codes and the modifiers are accurate to ensure that your proper reimbursement is realized. OPPS APC payments are calculated on CPT and HCPCS codes, which makes it nearly impossible to get paid correctly if your charge master is outdated or incorrect. And then also, you must ensure that those alternate HCPCS codes are built in your charge master correctly, so that when that's the code that Medicare wants, that your system is pulling from that alternate code column and sending the HCPCS code rather than that CPT code. Status indicators are helpful in determining which codes are billable to Medicare, so that information can be used when assigning charges in efforts to reduce your failed claims. So obviously, if you are a Vitalware technology customer already, and you're using Knowledge, you're aware that you can, look up those CPT codes and see just about anything you'd ever want to know about them. But looking at that status indicator and making sure that that code can be billed to Medicare. If it can't, that crosswalk is available to you to see the code that Medicare wants on the claim. And then I have added here modifier. Again, modifiers in fact can increase your reimbursement on any claim. Obviously, there are modifiers also that say, I don't want to, I know I don't get paid for this, and I don't want to get paid for this. But for the most part, modifiers oftentimes will give you additional reimbursement. So it's extremely important that your modifiers are appropriate. And then the next element, units, obviously has an extremely tight connection to your reimbursement. Billing 1 versus 400 of something that is payable is going to have a huge impact. And so ensuring that units that should roll to 1 on the claim are actually rolling to 1 on the claim. And then in reverse of that, that things that are not supposed to convert aren't converting. So looking at those drug charges, making sure that if you enter the charge once and that conversion on the back end flips that to 400, making sure that you're getting 400 times that payment is extremely important. This is something that we validate when we do our claims review piece of the CDM review. So again, looking at that in action, we can see that the drug was charged, and then on the claim, we can see if that billing conversion, the billing unit conversion happened appropriately. So that's extremely important when you're looking at anything related to pharmacy, especially those high dollar chemo drugs that you get paid for, really looking to see how many units are coming out on the claim on the back end to see that those conversion factors are working. That's one of the reasons that we look at the UB, even though in the CDM, when we get the pharmacy file, we usually have that, and depending on where you work, what your system you're on, whether you call it a billing unit conversion factor or whether you call it a bill unit multiplier, but basically it's that magic number behind the scenes that converts the amount given to that drug HCPCS code quantity that you could be getting paid off of. So again, we validate that during the CDM review process, looking at that line, but then also seeing that in action by validating that on the actual UB, it has converted appropriately. And then the last price, the last bullet here is price. And although in most cases, you know, with Medicare, they're going to pay you the APC rate, even if you charge less than the APC rate. But that's not the case for most other payers. So your managed care payers, most of them have a line in your contract that includes that lesser of language, meaning that they'll pay you X dollars unless you charge less than that, then they'll pay you less than that. So part of our review, you know, we have the ability to compare your price, and if you use Vital CDM, you have this ability as well. Compare your price to the APC price or the APC payment, the fee schedule payment, payment of up to 20 of your peers, what they are charging, looking at your state prices, and then percentiles. So there's very different approaches that you can take to validating your pricing and seeing how your pricing sits in the industry. Right now with price transparency, there's, you know, a big flashlight on the price of everything in the chargemaster these days. It's out there for the public to see. And so really getting comfortable with what your pricing strategy is. Are you comfortable with that? Not only from, is it covering my costs and hopefully making me a profit, but am I comfortable with the logical approach to how we set those prices now that they're available to the world? Obviously, you know, hospitals want to be reimbursed appropriately, you know, not too little, not too much, with the least amount of compliance risk. And then the next is revenue capture. So obviously, I've spent a lot of time saying the word compliance. And again, I feel like that really is something that should be considered in every decision we make in healthcare. But revenue capture obviously is key to compliance and to your reimbursement. You know, fundamentally, the goal is to capture and appropriately communicate the cost of providing services. Our CDM review can identify missing charges. In other words, those charges that for things that you perform but you're not currently charging for. So there isn't currently a charge in your chargemaster for that. Sometimes we find that in simple view of code ranges. Sometimes we find that in the claims review. But obviously, if there are services that you're providing that you currently can't charge for, that's, you know, a lack of capturing your cost. And so the message you're sending to your payers is that something isn't as costly to your organization as it actually is. Sometimes these are just maybe a misunderstanding of the charging guidelines. Sometimes this could be due to the way the charge description was written. So there might be a second code in that code series that says each additional, and on the first charge, someone just called it each. And so no one would question that because it just seems that we just enter this one charge every time. So we try to look at that too to see if it appears that some of those primary codes or add-on codes are missing. And then based on things we see documented in the charts, we can see if there are, you know, they didn't charge for X. Well, why? We go refer back to the chargemaster. Well, there isn't a charge for that. That's why they didn't charge for it. The other way to identify missed charges, so missing charges are charges that you don't currently have in your chargemaster. Missed charges then are charges that exist. The service was rendered, but the charge never made it to the claim. So they're missed at the time of either charge entry or one of those other problems that caused it not to fire. These are also sometimes called loss charges. And I would say the majority of those are generated either by human error or by oftentimes some kind of system error where maybe it's a system linkage issue. Once you find something like that, you really want to get to the root cause. So again, trying to figure out, working backwards, figuring out, is it the system? Is it an education opportunity? And it's simply a conversation with someone responsible for charging for that department to give them a better understanding of how to charge for particular services. Late charges can also result in lost revenue depending on what your late charge policy says. So I've seen late charge policies all over the board where you have X days as a clinical department to get your charges in. If it is beyond those days, you can't even enter the charge if you tried. So the system shuts you down. In other instances, the charge is allowed to be entered, but then there is a threshold of the amount of dollars associated with late charges, and then there's a decision whether you're going to enter those or rebill those or not. So oftentimes, late charges can be a big area of revenue loss. And the best advice I have is to monitor late charges, figure out if you have, just a handful of offenders, work with those offenders, figure out why that's occurring. There are going to be departments that are going to have late charges due to the nature of their business. So oftentimes with like pathology, something needs to be sent out to another lab to be evaluated. Sometimes that bill drop happens prior to the logical amount of time that process takes. And so that's kind of normal. You can decide to hold the claim or rebill those additional charges depending on the cost, again, and how that factors into your late charge policy. Again, failed claims, obviously claims that are not addressed appropriately. It could be either you're getting overpaid or you're getting underpaid. So that can be a huge area of lost revenue. So oftentimes I've been at places where there's not a really good understanding of what the edits mean. And so one of those edits is fired. There's a misunderstanding. A modifier actually is appropriate, but the person working those edits thinks that that means you can't charge that on the same day ever, and they just credit the chargeback. When actually, in many circumstances, a modifier is appropriate, and had it been applied, your gross charges are still going to be captured, and then hopefully some additional reimbursement on the back end. I think it's a really big area of focus, failed claims. I think they're kind of fun. I think it takes a unique type of person to do this on, all day, every day. They're kind of like a puzzle. You are going to find a lot of patterns that are going to be the same thing over and over again. But the biggest advice here I can give you is that as you do identify those patterns, if it is an educational opportunity, provide the educational back to the originating department, and hopefully then you'll see those decrease. But really figuring out the cause, make the corrections, and then you'll start seeing mostly just those normal things that happen as the course of business. and keep those at a manageable number. Obviously, assigning the right staff to these is hugely important for your revenue, but also your AR days. Somebody that knows how to work these can get these out the door corrected and with the highest level of accuracy. The last thing I mentioned here is understanding what is billable by the hospital and what is billable by the physician. I see some confusion here sometimes where we're noticing that large things like anesthesia isn't charged at all. And to me, when I look at a UB and there's no revenue 370 and there is a surgical procedure, my question is, if they had an appendectomy, how did they not get anesthesia? So having that conversation, why are there no anesthesia charges? Do you roll them into your surgery? Well, no, we were told the anesthesiologist charges anesthesia. So we don't charge that here. That absolutely is chargeable, revenue code 370 on the hospital side. And so again, that's one of those, just an example of one of those areas where it's all generated from a lack of understanding the difference between hospital and physician billing. Obviously, from the hospital side, I have seen some payers that are asking for the anesthesia CPT codes, but most don't want them on the claim from the hospital side. That's sometimes random Medicaids I have seen ask for those. But just really, having a really good understanding of what you can and cannot bill is going to have a really big impact on your revenue capture. Transparency, again, like I said, hopefully you've also survived meeting the transparency guidelines. With this new requirement to include a consumer-friendly display of the shoppable services, contracted payment rates. Obviously, again, like I mentioned, it's really important that you're comfortable with your pricing strategies at your organization, that you're taking a look at those, doing some comparisons, making sure that you're comfortable with that. Competition, obviously, you want to make sure that you're being competitive in your vicinity. How much competition do you have for physical therapy services? Are you as a hospital competing with a freestanding PT group down the street? And maybe you want your prices to be lower than theirs. But really looking at that information. Oh, sorry about that. And then looking at your cost to charge ratio. What does that cost markup look like? Do you know your cost? Do you know how to figure out your cost? I think that's sometimes the bigger question is that we hear is that, at least from the clinical side, is that we don't even know what our cost is or how to figure that out. We've been here a long time. We just do 3% increases every year. So I don't even really know what my cost is. We've never sat down and figured that out. So that's a whole nother exercise that's super important to look at what is your cost and have you covered your cost in the prices that you're currently charging. We do have, within our technology, there are some reports that compare your cost to your charge if that data is loaded, obviously. We see that most often, in supplies and drugs. But that's one area that you can get that data right out of your technology if you use Vitalware. All right, so wrapping up, hopefully I've been able to demonstrate that there is certainly a great value in partnering with someone like Vitalware to perform an annual CDM review. I think it's great to get an outside perspective, but I also think it's imperative that this process take place, whether you undergo this internally or do engage with a partner to help you through this process. This, the CDM just really is the foundation of your revenue, both your gross and your net, and the interactions between the CDM and these other systems within your hospital. As we get more and more technology, that interaction in between those systems becomes more and more complex, which only allows for more error, more system issues, and as I mentioned before, the breakage between those linkages between those files. And that, coupled with the complexities of the coding and billing regulations and ramifications of coding and billing errors, can really have an impact on your organization's bottom line. So I hope that you found this helpful today, and if you would like to have any further discussions with us, with me, certainly be happy to talk with you about any CDM review needs that you may have with your organization.
Great. Thanks, Wendy. Just a quick reminder, we got about 5 minutes. We'll do a couple Q&A here. If you do have questions, you can put those in the Q&A panel. After the webinar here, we'll be emailing out your CEU certificates for the AAPC and HEMA, and so expect those shortly. You can always rewatch this webinar or send along to a colleague if you think it'd be helpful for them, and download the presentation at vitalware.com/webinars. You can see all future and past webinars on that page. And with that said, we got a couple questions here. We'll take a look. All right, Wendy, this one looks pretty specific, so let me know if we can get this or not.
Okay.
But, okay, while diagnostic coding and Medicare patient, CPT code 85025 gets edit 3124 3M duplicate lab or path code. Add modifier. Vitalware shows acceptable modifiers are 59, 91, XE, XP, or XU. Can we pick modifier XU for this duplicate lab for Medicare patient, or do we have to pick 91? A lot there.
Okay, the first one is 85025. That's a CBC, I think. What was the other one?
It gets to edit 3124 3M duplicate. And then the modifier.
Oh, the duplicate. Okay.
Yep.
If it's 2 units of 85025, typically it would be the 91 repeat lab. Although I have heard most recently that some folks are using the 59 on those because they're saying their system doesn't allow the 91 to pass. But I'll definitely try to find some support for that, and when we send out the Q&A answers.
Sounds good. One more here, quick. Well, maybe it's not quick. Could you touch on the OPPS rule and the fact that the facility and the physician can bill for the same CPT but are reimbursed differently? Any insight into that?
Okay, let me see if I understand that. The facility and the physician submit the same CPT but are paid differently?
That's what they're saying, yep. Okay.
I'm not sure what you're asking, but yes, if trying to think of an example. Well, let's just say the appendectomy. Let's just use an appendectomy. So patient comes into your hospital to have an appendectomy. The hospital is charging for the use of the operating room, the use of the equipment, the overhead, electricity, supplies, the nursing staff, the surgical techs, to perform that surgery in your hospital, and the facility is being reimbursed for that. The physician then is billing for actually performing the surgery, and then he is going to be paid for that piece as the surgeon. I'm not really sure if that answers your question. If it doesn't and you wanted something way more specific than that, just put it in the chat, and we can definitely include that in our Q&A response.
Looks like that answered it for them based on the response here. Great job. And someone just asked in the chat. So yes, we'll be emailing the CEU certificates by email following the webinar here. And we do not have any more questions, and we're out of time. So that's a good combo there. We appreciate everybody for joining us. Again, you can go to vitalware.com/webinars to look at the upcoming webinars we have, or follow us on LinkedIn is a great way, or we have a newsletter that you can follow as well, where we try to keep everybody up to date with what's coming up for content and resources for you. Thanks again for joining us, and we will see you all soon.
Thanks, everyone.